Hi guys, so today we're continuing with BLS. I want to just quickly go over using AED for children and infants, and I also want to talk about rescue breathing for adults, children and infants today. In one of my previous videos, I already spoke about using an AED machine for adults, so today I just want to focus on using an AED machine for children and for infants. So there's actually two components to this. So there's the shock dose and the pad size and the pad placements as well. So let's first address shock dose. So the adult AED machine, or just the AED machine in general, you could reduce the dose to a pediatric dose by different mechanisms. So firstly, you could do pre-programming of the machine if it allows you to do that. You could use pediatric cables, or you could attach an attenuator to reduce the dose, which is going to be suitable for kids. I think attaching the attenuator could reduce the shock dose to by about 2/3. Also, the child pads or the pediatric pads are used to deliver the reduced shock dose, which is appropriate for kids. And now moving on to the pediatric pads themselves. You should just use the pediatric pads if the victim is under the age of 8. So anyone over the age of 8, we use the adult pads. Also, the pediatric pads, I think they're only designed if the victim is under 25 kilograms or just under 55 pounds. But if we don't have the pediatric pads available to us, then we can definitely use the adult pads. And it's much better to actually use the adult pads than to not use the AED at all. So there are a few things to consider when we're going to use adult pads for pediatric victims. So firstly, the pads shouldn't touch each other or shouldn't overlap. For instance, you have a child victim, so I'm going to pretend I'm the victim. We have two different placement options, as I've discussed in the previous videos. We have the anterolateral and the anteroposterior pad placements. So anterolateral, just to recap quickly, is we place one pad below the right clavicle, just about that, and on the left side mid-axillary, just kind of below the nipple line, just that. So as long as they're not touching each other, not overlapping, then that's fine. And the anteroposterior placement can be used for really tiny infants, so the pads don't overlap if you're going to use adult pads. So we place one on the anterior side of the chest on the left side, and we could place the other pad posteriorly, so on the back on the left side. So let's recap the most important things. So firstly, we can definitely use adult pads for pediatric victims if we don't have pediatric pads available, and this is because adult shock dose is preferred over giving no shock at all. And the second important thing to remember is that although we can use adult pads for pediatric victims, we can't do the other way around. So we cannot use pediatric pads for adult victims. And this is because the shock would be reduced too much to the point where the dose would not be effective at all for adult patients. Moving on to using AED for infants. So these are the victims that are less than 1 year old, excluding the newlyborns. For these victims, manual defibrillator is actually preferred over an AED because it can provide reduced doses for the shock. But if we don't have a manual defibrillator, and because you need like an advanced training to be able to operate one of these machines, we can use an AED that is equipped with an attenuator, so a pediatric dose attenuator. If we don't have that as well, then we could just use an AED machine without the pediatric dose attenuator. Let's quickly run over the Bls sequence for children. Let's include using the AED in the sequence. So first of all, when you see a child victim lying on the floor, we first verify the scene. So that means that we are checking for any hazards. For instance, if the child got hit by a car, then obviously we don't want to perform CPR in the middle of the road because the other cars are probably not going to see us and we're going to be a victim ourselves. So what we do is we move the patient to like a safe environment where we could continue our assessment and we can give CPR safely if needed. So after verifying the scene, what we do is we check for responsiveness. So we do this by giving both tactile and verbal stimuli. So tactile stimulus is basically just shaking the patient or tapping the patient, and the verbal stimulus would be just asking, hey, are you okay? And if there's no response, then if we're alone, Firstly, call emergency rescue system. Activate the emergency rescue system. Call the emergency services, because you could be there for God knows how long if you don't have any backup that's going to be coming along. If there is another person around, then you ask them to please activate the emergency response system and call the emergency services. So after the activation of the emergency response system, then we check for breathing and for pulse. We have to do this within 10 seconds, and we have to do them simultaneously just to save time. So for breathing, we need to look, listen, and feel. So look for the rise and fall in the chest. We can get close to the patient and listen for breath sounds and feel the air coming in and out of their mouth or their nose. So if we don't have that, then that means there's no breathing. And we check for the carotid pulse, which is between the trachea and the sternocleidomastoid muscle. If we find that our victim doesn't have any pulse or any breathing, then we could start with CPR. And we could ask another person to go grab the AED machine for us. But if we have the AED machine already with us, so for instance, we brought it with us when we were activating the emergency medical services, then we can attach the AED pads directly onto the victim before we start decompressions. Usually there's a guide on the AED case as to how you're gonna attach the pediatric pads, but it can just be either anterolateral or anteroposterior, as I've described earlier. As long as the pads are not touching then or overlapping, then you should be good. So once you attach the pads onto the victim's bare chest, it will analyze the rhythm. So it would prompt you to clear the victim, and it would be like, it would say like analyzing rhythm, and it would take a few seconds. So if the AED machine senses that it's a shockable rhythm, it would prompt you to deliver the shock. And when you deliver the shock, you have to make sure that no one else is touching the victim. And after administering the shock, then you continue immediately with the chest compressions and the rescue breaths in the ratio of 30-2. If, for example, the AED machine says that, it's a non-shockable rhythm, or just says no shock advised, then just immediately resume with your chest compressions and rescue breaths. You're gonna do the chest compressions and rescue breaths in a cycle until the AED machine prompts you for another rhythm check, or if the emergency medical services arrive, or if the patient regains consciousness. So moving on to rescue breathing, we provide rescue breaths to victims who has a pulse, but they're not breathing normally, or they're not breathing at all on their own. So we do this, there's two methods to do this. For adults and children, mouth-to-mouth is usually preferred. And for infants, mouth-to-mouth and nose is commonly preferred over just mouth-to-mouth. So to do adult rescue breathing, you provide one breath, so one rescue breath per 5 to 6 seconds. So that means it's gonna be 10 to 12 per minute. And with each rescue breath, you're looking for a rise and fall in the chest, indicating that the breath has actually gone into the lungs and gone out, which means that it's an effective rescue breath. If you don't see this, then you might have to look for like an obstruction, check that the airways are patent. So you keep doing rescue breaths for about 2 minutes, and at that 2-minute mark, you have to check the pulse, just to check if the patient still has a pulse, and if not, then you start compressions. So when providing rescue breaths in children and in infants, the rate is quite different. So we provide one rescue breath per 3 to 5 seconds. So that's 12 to 20 in a minute. And it's the same principle. We look for the rise and fall in the chest with every rescue breath, just to make sure that it's an effective, that we're giving them effective rescue breaths. And every 2 minutes, we check for the pulse. If there's no pulse, or if there is like signs of poor perfusion, like if the lips are turning blue, if the infant or child is becoming cyanotic, then we commence with our CPR. So we start our chest compressions. Now let's describe the proper mouth-to-mouth technique when giving rescue breaths to children and to adults. The first thing that we do is we try open up their airway. So we do that by doing the head lift, chin tilt method. So we just do that. So we push that and that, just to make sure that their airways are open before we administer rescue breaths. And then after that, we pinch their nose with our, sound funny, with our thumb and index finger, just so the air doesn't leak out. And we basically put our mouth to the patient's mouth, creating an airtight seal, again, to make sure that the air is not gonna leak out. And then we take a normal breath. We don't take a deep breath in, we just take a normal breath and breathe into the patient's mouth. Each rescue breath, we have to deliver over 1 second. And again, we need to check for the rise and fall in the chest as we do this. So for infants, as I mentioned earlier, the mouth-to-mouth and nose method for rescue breathing is preferred over just mouth-to-mouth. But if you can't cover the infant's mouth and nose with your mouth, then just revert back to mouth-to-mouth. To do this technique, we approach the infant victim, and there's no need to tilt their head. We just have to keep their head in a neutral position, and we try to cover their nose and mouth with our mouth, creating that airtight seal with our lips so no air leaks out as we deliver the breath. We try blow air into the infant's nose and mouth, each breath over 1 second, making sure that we deliver just enough air to make their chest rise. It's very important to remember that for infants, we shouldn't blow too much air or blow too rapidly, because this risks the air going into the stomach instead of the lungs. So you shouldn't really take like a deep breath in and then blow into the infant's nose and mouth. Just take normal breaths and make sure that you deliver the breath over 1 second. So not too quickly, not too abruptly. If you do so, then this would lead to gastric inflation. So that's the inflation of the stomach, and this can lead to other serious complications.